In the soft rustle of rice paddies beneath the humid summer skies of East Asia, an invisible war once waged, a war not of men or empires, but of nature itself. There, hidden within the tranquil hum of the countryside, a small creature carried a passenger so devastating, its name would echo across generations: Japanese encephalitis. Let us step back in time. The year is 1871. Japan, having just opened itself to the world after centuries of isolation, was now facing a new visitor, one far more insidious than any foreign fleet. That summer, in the southern prefectures, reports began to emerge. People, seemingly healthy, fell into fever. Headaches intensified. Confusion set in. Some slipped into comas. Many never woke. At first, the cause was unknown. But the signs were there. Brain inflammation. Neurological collapse. A pattern, seasonal, rural, and inescapably tragic. This was the beginning of Japanese encephalitis. Though it had likely simmered beneath the surface of East Asia for centuries prior, it was now, with the advent of modern medicine and record-keeping, being documented. And it would not go unnoticed for long. The culprit? A virus. Small, RNA-based, a member of the flavivirus genus, the same viral family that gives us yellow fever, dengue, and Zika. And it had found a perfect delivery mechanism: the Culex mosquito. But unlike a solitary threat, this virus had a complex ecological web. It thrived in the rural lowlands where humans, pigs, and birds shared space. Wild wading birds, such as herons and egrets, served as natural reservoirs. Pigs, however, domesticated and clustered in villages, became amplifying hosts. When bitten by an infected mosquito, the pig's bloodstream became a viral factory. And the mosquitoes, in turn, would transmit that virus to humans, especially in the warm, wet months of summer. By the early 20th century, the disease was spreading its wings. It reached the Korean peninsula, China, Southeast Asia, and parts of South Asia. The pattern repeated. Annual outbreaks. Hundreds, sometimes thousands, afflicted. Children, tragically, were the most vulnerable. In 1924, Japan experienced its worst epidemic. Over 6,000 people were infected. Nearly 4,000 died. Those who survived often faced lifelong neurological impairments, seizures, paralysis, and cognitive decline. These were not just statistics. These were sons, daughters, parents. Entire communities were scarred. In the decades that followed, research intensified. Scientists sought to understand the mechanisms of transmission, and more critically, how to stop it. It became clear that the virus did not transmit directly from human to human. The mosquito vector was essential. Control that vector, and you could slow the spread. Early efforts focused on controlling mosquito populations. Stagnant water was drained. Insecticide spraying campaigns were launched. But in rural areas, where rice farming was essential and irrigation systems abundant, the challenge was monumental. You cannot simply erase the environment in which people live. A breakthrough came in the 1930s, when Japanese scientists began developing a vaccine. By 1941, a formalin-inactivated mouse brain-derived vaccine had been introduced, a crude but effective first step. Mass vaccination campaigns began in earnest during the 1950s. The results were staggering. In Japan, where immunization became routine for children, the annual number of reported cases plummeted from thousands to mere dozens. The virus had not disappeared, but its reach had been sharply curtailed. Elsewhere, however, the story remained grim. In rural Vietnam, Cambodia, India, and Nepal, Japanese encephalitis continued to strike. Outbreaks ravaged villages. Hospital beds overflowed with children suffering seizures. Often, medical care was too little, too late. The virus's cruelty lies not just in its lethality, but in its subtlety. For every one person who develops symptoms, There may be 200 others silently infected. The body fights. The virus hides. And for those unlucky few, the immune system fails to protect the brain. Even today, the statistics command attention. Japanese encephalitis causes an estimated 68,000 clinical cases annually across Asia. Of those, approximately 20,000 will die. Up to half of the survivors live with permanent disabilities. And most tragically, this disease remains largely confined to children under the age of 15. And yet, this is a preventable disease. Modern vaccines are now safe, effective, and widely available. The newer, cell culture-derived vaccines have replaced the older versions. Immunization programs have expanded across Asia. In countries like China and India, the virus has met significant resistance thanks to these efforts. But not all regions are equally protected. In areas where infrastructure is weak, where healthcare systems are underfunded, or where political instability prevails, the virus still strikes. Vaccination rates vary widely. Surveillance can be limited. The virus continues to flow through the veins of wetlands, through the air in mosquito wings. So, how do we stop it? The key lies in a three-pronged strategy: vaccination, vector control, and public awareness. Vaccination remains the single most effective tool. By immunizing children in endemic regions, we cut off the virus's primary target population. Herd immunity, once achieved, dramatically reduces outbreaks. Vector control must be adapted to local environments. While widespread insecticide use has its drawbacks, community-level interventions, like mosquito nets, larvicide treatments, and water management, remain essential. And finally, education. Awareness campaigns can inform families about peak mosquito hours, encourage the use of repellents, and dispel myths that might prevent parents from vaccinating their children. In recent years, climate change and rapid urbanization have complicated the picture. Warmer temperatures and erratic rainfall patterns are expanding mosquito habitats. Rice cultivation has spread into new regions. And with it, the reach of Japanese encephalitis. It is a reminder that diseases, like nature, adapt. As we build, expand, and change our world, we alter the delicate balance of ecosystems, sometimes in ways we do not immediately see. But there is hope. The World Health Organization, in partnership with governments and non-profits, has committed to reducing Japanese encephalitis cases through the Global JA Control Initiative. Millions of children have been vaccinated. New surveillance tools are being deployed. And scientists continue to work on next-generation vaccines that are cheaper, safer, and easier to administer. Today, in the same rice fields where the virus once found its strength, children laugh and play, protected by the very science their ancestors never knew. This is the story of Japanese encephalitis. A story of tragedy, yes, but also of triumph. Of resilience. Of science rising to meet the challenge of a silent storm. As we reflect on its journey, we are reminded that the fight against viruses is not just fought in laboratories and hospitals. It is fought in villages, in classrooms, in families who choose to vaccinate, in scientists who refuse to give up. And though the virus may never be fully eradicated, we now hold the power to ensure it never again claims the future of a generation.